Good morning, everyone. You're all excited? Welcome to the second day of KidneyCon. We have some interesting sessions lined up today. We will start our day with kidney pathology workshop. So when you started your nephrology fellowship, like in the very beginning, we were aware of minimal change disease, membranous, those were easy. But as the fellowship progressed, the terminology itself was so difficult, right? By a lot of effort, we got to know what is focal segmental glomerulosclerosis, right? As the fellowship progressed, we started understanding what is the pathogenesis behind that. But then gradually we realized FSGS is not even a disease, it is just a morphology. And then gradually, as we moved forward in our fellowship, we realized most of the diseases which we talk about in kidney, they are just morphological patterns, they are not even disease. So we have understood that concept from the perspective of light microscopy, that most of the diseases which we see are morphological patterns. But today what we are going to do, we are going to understand the same concept from the perspective of immunofluorescence. Because IF or immunofluorescence is very important. When a kidney pathologist starts their day, most of the time they start their day with IF. We look at the IF slides first, and then we look at the light microscopy. So immunofluorescence is very important. So today we are going to discuss some of the diseases, some of the cases in which we will start, and we will look at the pattern of IF, and then we'll see what is the meaning of that pattern in a context of a case. And throughout the session, you will have multiple opportunities to ask questions. We want this session to be very interactive. We want your everything today. I want your 100% attention. Ask me a lot of questions. I will handle the chat box, and Alejandro Best and Chris Larson are going to present cases, and I'll be moderating the chat box. I will be happy to stop them if there are enough questions, if we need to stop them, but I want a ton of interaction during the session. So ready?
Dr. Sharma, I'm just going to pause you for a second. I wanted to do a little bit of an introduction to get everybody oriented to the platform and officially welcome everyone to KidneyCon 2021. We saw many of you at the career development session yesterday, and that was really excellent. My name is Samira Farouk. I'm a transplant nephrologist at Mount Sinai. Matt, did you want to introduce yourself and say a couple things?
Yeah, hey everybody, Matt Sparks. I'm a nephrologist at Duke University, and I'm really happy to actually be able to attend all the workshops today.
I'm Shri Sharma. I'm a kidney pathologist at Arcana.
And any questions or comments, please feel free to share them in the chat. Several of us will be monitoring that, and we want this to, as Shri said, have this be as interactive as possible, similar to our other Arcana Live sessions.
All right, are we good to start?
Yes, Alex, we're good to start.
All right. Well, I'm going to really second what Shri just said, and neither Chris or I are really prepared to give a 2-hour lecture. All right. This has to be interactive, and Shri will be helping us at reading questions, answering, bringing up whatever needs to be addressed in public. And for those of you who don't know Shri, if Shri gets bored, he gets in trouble usually. So please keep him busy throughout these 2 hours, and we'll be better off that way. So let's get started. So, and Shri did a brief introduction regarding this, but on previous workshops that we've done over the years, we usually focused on light microscopy, and that's a very common approach of doing these type of sessions. We used to cover the normal morphology of the kidney, and every single disease we talked about, we started from the light microscopy, and then we showed the immunofluorescence electron microscopy as ancillary studies. Today we want to change that a little bit, and we're going to do these very immunofluorescence centric workshop. And this makes a lot of sense because immunofluorescence gives you a lot of understanding regarding the etiology of the disease. And in real life, and we'll touch on that in a few minutes, in real life, that's kind of how our brain works. We start with the IF, and then we branch to the light microscopy and electron microscopy. So I hope we can really show that during the next 2 hours. Over the next few minutes, I'm going to give you an introduction on immunofluorescence. For a lot of you, these may be very basic information, especially if you work or have worked in a basic research lab, or you did pathology rotations during your medical school, etc. but maybe some of you have not experienced that. So in order for us to be on the same page, we're just going to take a few minutes to cover this. So what happens after we take a biopsy from a patient? What happens to the tissue? This is very variable, and this changes from institution to institution. Some places, IR, or most places nowadays, IR does the biopsy. Other places, still the nephrologist do the biopsy, especially in pediatric setting. Sometimes, or some of you work in institutions where the tissue gets processed, stained, and read in-house, while many of you work in places where the tissue gets shipped to central or reference laboratories. So what I'm going to say doesn't apply exactly the same way to everyone, but basically, either is the radiologist, the pathologist, the nephrologist, someone has to triage that tissue. What that means, someone's going to put a piece of that tissue in formalin for fixation, which eventually you'll do your light microscopy slides out of that tissue. Someone will put a piece of tissue in Michel's transport media, or if you stain in-house, if you have pathology that stains immunofluorescence in-house, that tissue may never make it to Michel's, because from the bedside, it goes straight to the lab and gets snap frozen. But I think that's a minority of you nowadays. And depending on where you work, you may take a little piece and put it in glutaraldehyde for electron microscopy. Although here at Arcana, we do our electron microscopy from the formalin and fixed tissue. So this is kind of like just the gist of what happens to the tissue after it gets taken from the patient. Now, what happens when we get to the lab? So in a nutshell, that tissue that comes in Michel transport media will get washed, will get blotted, and then it will get embedded. And the embedding process, it's not trivial. I mean, you have to really know what you're doing. You have to start with a really flat surface, really embed your tissue in a way that facilitates the read eventually when you get the slide on your microscope. So you have to be really careful with this step. Then we cover it with embedding media. This is OCT. We freeze it on the cryostat, and then we can start sectioning. Since we're dealing with very, very small pieces of tissue, as soon as we get into the tissue, we start picking up the slides, right? We can always go deeper, but there's no way to go back and get the tissue that we already lost. So in that sense, we're very cautious how we use the tissue. When you make your section, and these are 4-micron sections, you can start picking your slides, and these slides are the ones that will eventually be used for immunofluorescence. Every lab is different, right? Here at Arcana, what we do, like I said, we start picking up tissue really superficial because we don't like to waste any tissue. So we collect slides for all our stains, and then we go back and do a deeper level on the same slide, again, on all the stains. That way, on each stain, you have a superficial and a deep level, and the chances of missing the lesion decrease significantly with that approach. Anyway, after we have our stains ready, now we're ready to stain them. So there are 2 different ways you can do immunofluorescence, and really the main concept, the principle is the same. You're basically applying an antibody to the tissue that is specific for the target of interest, all right? Where the difference occurs is you can have that primary antibody, the one that has specificity for your antigen of interest, you can have that one tagged with a fluorophore, which under fluorescent light, you can identify if the target is present or absent, or where it's present, if it's present. But you can also do an indirect immunofluorescence where the primary antibody is not tagged, but then you apply a secondary antibody that one is tagged, but instead of recognizing the antigen of interest, it really binds to the primary antibody that you applied initially. I mean, just variations of the same idea, right? So, but each of these methodologies have their advantages and disadvantages. Direct immunofluorescence, for example, it's very helpful for us in the clinical lab because it's faster. It's only one step, and time is very important for us. You guys are waiting for our call, so anything where we can cut time, it really helps us. You also, because you're only using one antibody instead of multiple antibodies, you decrease the non-specific staining or background staining. So it's more specific. You do lose signal. You do lose intensity. because it's a 1-to-1 ratio, right? You have one antibody with one fluorophore for one target. If you do indirect IF, every time you add more antibodies, you're kind of like multiplying or amplifying that signal. However, for our purposes, the molecules that we're targeting are usually very abundant when they're clinically significant. They're larger molecules, and we use, for the most part, polyclonal antibodies. So it will bind to different epitopes of the molecule. So that way, in a sense, we can kind of go around that lack of intensity on the direct IF. What really it's not ideal is the sense that you depend on what the manufacturer wants to produce and sell you, right? You have less options in terms of species, fluorophores, etc. So when you're trying to do more fancy type of staining with multiple fluorophores, etc., multiple targets, then you're more limited in that sense. But for our routine, it's very helpful because it's fast. You just apply the antibody, incubate for 30 minutes, wash, cover slip, and it can be read. So really, this can all happen in less than an hour. All right. So in that sense, it's very, very helpful for a clinical lab like where I practice. So this is pretty standard across laboratories. Most places will do routinely on every single case 3 heavy chains, IgA, IgG, IgM. We'll do light chains, kappa and lambda. We'll do 2 complement stains, C3 and C1q. And very frequently, most labs will do albumin and fibrinogen. If it's a transplant, obviously you have to include C4D to the list. I do want to emphasize in 2021, if you work at a place where they don't do kappa and lambda, I think you really should push the lab. Kappa and lambda in the past wasn't done routinely, but now we know so much about monoclonal related diseases that it must be part of the routine panel. So real quick, what happens if you don't have tissue for immunofluorescence? And that happens, you do a pass, you put in formalin, your patient starts bleeding, you have to stop the procedure. Or, it happens, you get fat or you get medulla and you don't have gloms for immunofluorescence. We just don't stop and say, there's no IF. There's tools we can implement to go around this. For a while, we've known now that if you take your formalin fixed paraffinated tissue, you deparaffinize it, you do a pyrolytic enzyme retrieval step, you can do most of your IF stains, and they do work. And they do work on most diseases. So initially, the concept was that this was a salvage technique. We would only use this when we didn't have tissue for routine or frozen tissue for immunofluorescence. And it was better than nothing, right? It was the alternative. It's not ideal, but it worked, and it saved you sometimes or frequently. With time, we learned that it's not only the purpose of, it shouldn't only be a salvage technique. In fact, there are many diseases where if you don't have paraffin immunofluorescence, you just cannot make certain diagnoses. Or sometimes it just helps you when you're not sure about a diagnosis. It's just one more tool that we have in the lab to reach a final diagnosis. So it's really very helpful, not in those cases as a salvage technique, but also beyond the salvage technique. This is a little bit older paper. It's from 15 here from the lab. And at that point, we did 300 cases during the study period, and 2/3 were salvage, but already 1/3 of the paraffin IFs that we do are not as a salvage technique, but for other purposes. I think between that point and now, it may be even more the case because we've learned about more diseases that quote unquote mask, and we'll touch on this in a little bit. Like I said, paraffin IF is not ideal, and it will, I hope it never substitutes frozen IF. It's harder to read, and there are certain diseases that just don't perform as well in paraffin IF as compared to frozen. This chart that I have here, it's helpful, but that's not our experience. This is Mayo experience, which is a little bit different than ours, but the concept is the same. Like anti-GBM, we agree that when you do anti-GBM on paraffin tissue, you can miss it. It doesn't perform well on paraffin IF. MIDD, either light chain or heavy chain deposition disease, it doesn't work well on paraffin IF. C3 in general doesn't work well on paraffin IF. That's why, on some certain types of infection-associated, it's not ideal. But there are others, especially crystalline type diseases or monoclonal diseases, that really doing paraffin IF brings that signal out. And a case that you would have called negative before, after doing the paraffin, you clearly see the monoclonal immunoglobulin. And again, we do have examples of this during the talk. All right, that was a very brief introduction, and I don't want to do more because I don't want to bore anyone. So now let's go to the fun stuff. Let's go to the microscope. What does IF look like? All right, let's start with the negative. In medicine, they always tell us you have to learn the normal to identify the abnormal. So negative in this case is the normal. And, for routine, we use FITC, which is a green fluorophore. And you see green here, but it doesn't mean it's positive. This is a negative. This is autofluorescence, right? When it's positive, it sparkles. It's bright and sparkles, like in this one. This is a really good example of a positive case. And the point I want to make with this slide is that it's not a box like, is it positive or negative? And you check it and you're done, right? If it's positive, you need to know or identify where the deposits are present. Are there glomerular deposits? Are there tubular interstitial deposits? Are there vascular deposits? And frequently, it can involve different compartments, like lupus, for example, that you can have involvement in all three, glomeruli, tubular interstitium, vessels. But it's not always the case. Like in IgG4 disease, you can have tubular basement membrane deposits, and that's a really nice clue, in addition to the light, to make the diagnosis. Cryo, for example, can have isolated, not usually, but can have isolated vascular involvement, for example. So identifying and looking through all your compartments is very important when you're looking at immunofluorescence. Now, obviously, we're very glomerulocentric. As renal pathologists, we focus a lot on the gloms. So when we have positive glomerular staining, we want to really know where it's staining. Is it mesangial staining? Is it capillary wall staining? And when it's capillary wall, we can even try to differentiate subepithelial versus subepithelial deposits, but this is not easy, and there are other tools, so we don't really hang our hats completely on that, but it's good by the time you're looking at your IF to start having like a mental differential diagnosis. And you can have, this is uncommon, but it's not only mesangial and capillary wall, you can have deposits in the Bowman's capsule. Sometimes the podocytes can stain. So it's important to really take the time to analyze your slide and really get as much information as you can from the immunofluorescence. The texture of the deposit is important. There are diseases that are characterized by very granular deposits. There are diseases that have more linear deposits, and we'll talk about those in a second. And I don't like that word, but you can have smudgy deposits where they're not really granular. They're more like if you just kind of like smeared the deposits. And each of these have their really nice diagnostic correlates, which really help us in the day-to-day practice of renal path. All right, why are we doing all of this? And I promise we'll get to cases really soon. The reason why we're going through all of this is because, at least in my practice, and I'm sure Shri and Chris practice the same way, the first thing you get in a case is the IF. So it's sitting in your desk. So you could wait for your lights to start working, or you can get started with whatever you have. And obviously we start with whatever we have. So because we almost invariably read the IF before the light, our mental algorithms when we're approaching a case start with immunofluorescence. And I'm going to give you a few examples. Let's say I get this case. I don't know anything about the patient. I put the slide on my stage, on my scope, and I see capillary wall, very granular deposits that are staining for IgG, kappa, and lambda with a little bit less C3. What am I dealing with? A membranous glomerulopathy, right? My job, obviously, it's not there. My job is not that easy, I promise. But at least you have a really good idea what you're dealing with, right? Of course, and Tiffany and others will talk more about this tomorrow, but we have to determine if this is primary, secondary. Now we have all these fancy markers. You have to see if there's chronicity or not. There's collusion diseases where you can have like a diabetic with a membranous, or, your job is not there, but at least at this point, you're dealing with a membranous. Same thing, you have a case, you have mesangial IgA staining, mesangial staining for IgA, kappa, and lambda with minimal G. Okay, I know I'm dealing with an IgA nephropathy, right? Of course, I have to do my MEST score. I have to try to differentiate primary versus secondary IgA, chronicity, etc. But I know I'm dealing with an IgA, and there's very little that I can see in light or EM that will change my mind. I already know it's an IgA nephropathy. If you have full house, for those of you who like to play poker, if you have full house, what we call full house deposits, well, I'm dealing with a lupus, and this is one of things that frequently people ask me on the phone. Is it full house? Well, lupus nephritis is not always full house, but when it's full house, it's almost certainly lupus. There's lupus-like pattern. I mean, it's not, again, my job is not done, but if it's a young female with history of lupus, well, I know I have lupus nephritis. I just have to do my ISN-RPS, activity, chronicity indices, etc. But I know I have a lupus nephritis case. If all my stains are negative, but I do have positive lambda smudgy staining in the mesangium and capillary loops, well, highly likely this is going to end up being an AL amyloidosis case. So even at this point, I can make sure I have a Congo red ready by the time I see my light microscopy, because I will need it. But I'm almost certain that it's an AL amyloid. What do we have here? We have very linear and very bright staining of only the capillary loops for G, kappa, and lambda. This is the albumin. The albumin, one of the reasons why we do it is because it sometimes will serve you as your control, right? So let's use diabetic as an example. Diabetic glomerulus membranes are frequently pretty bright. They have like a significant autofluorescence, but they will stain similar for G and albumin. So you're like, okay, this is not pathologic. I mean, it's just part of diabetic nephropathy, part of the spectrum of the disease. However, if you have really bright G with no albumin, then that's abnormal, right? Because your control is basically negative. In addition to the staining, there are some things that you can notice by dark field microscopy. For example, there's a lot of space between the capillary loops and the Bowman's capsule. And the Bowman's capsule is discontinuous, and you can even imagine some breaks of the loops. So I know this is a crescentic GN with linear IgG staining. So what do I have? ANCA? No, right? Anti-GBM disease. Again, my work is not done, but I know this is an anti-GBM. So what can I do in this case? I can prioritize this case. As soon as the slides come out, I can read them, even if I have 10 other cases, because this is a very sick patient, right? I mean, there's a nephrologist or a hospitalist or someone waiting for me. So I'm going to try to do this as soon as possible, thanks to the IF, because I already know what I'm dealing with. All right. So it's not always that easy, right? There is a pattern of staining where you only have C3 in the glomeruli, but everything else is negative. Well, this goes against everything that I've been saying. In this case, I really don't know what I'm dealing with. It could be a lot of things. And based on the demographic of the patients, based on the clinical history, based on the light microscopy and the electron microscopy, only then I'll be able to issue a diagnosis. And these diagnoses have completely different managements, right? So I can't be wrong. So this is one that I have to wait. I have to wait, and that's why we have 3 modalities, right? We have light microscopy, immunofluorescence, and electron microscopy. In this case, I'll have to go through everything before I can issue a diagnosis. So for the next hour and 35 minutes, we're going to go through the differential diagnosis of cases that have this exact pattern of staining, C3 only by routine immunofluorescence. As part of like the exercise that we're doing, this picture that you're seeing, this is the same picture we're going to show you in every single case we'll present. Obviously, it doesn't belong to every single case, but it's just to send the message that, that they can look identical, and that's why you need the other modalities to reach a diagnosis. All right, so I'm done for now. I'm going to send it over to Chris, and we'll take it from there.
All right, thanks, Alex. I appreciate that introduction. I'm going to start with a case, and I'm going to tell you about a biopsy that I read about from a 6-year-old boy. And you can see the history here. Creatinine was 1.1. He had hematuria, proteinuria, hypocomplementemia, ASO was elevated, reported a sore throat and fever approximately 3 weeks ago. So probably if you based on this clinical history, you already know what this kidney biopsy is likely to show. As Alex pointed out, part of what we want to do today is we want to talk a little bit about histology and kind of histopathology, what we see as pathologists on these biopsies. And also, Alex presented a lot of the classic findings. And these are the board type cases, but today we're going to present some of these classic type pictures, but we're also going to present some diseases that are actually quite esoteric. And the reason for that is we want to really show the caveats that exist in renal pathology and how frequently the things that you see on the boards or the classic findings are not always the case. And so this is a case of a classic, very classic histopathology. Based on that history, you probably suspect that this patient has a post-streptococcal glomerulonephritis. And in fact, if we look at these glomeruli, you can tell that they're very hypercellular. If you just look at this glomerulus, what you're looking for is you're looking for the mesangium, you're looking for the capillary lumens, and really you can't identify any of those. All you can see are cells. And when you focus in on a higher power, you can even pick out different types of cells. These are polymorphic leukocytes. So this is a neutrophil, probably an eosinophil, lots of neutrophils, monocytes, swollen endothelial cells. So we have a very hypercellular glomerulus. So this is a so-called proliferative glomerulonephritis. You'll hear buzzwords like exudative, proliferative, and exudative glomerulonephritis. Classic picture for exactly what we would expect to see on this biopsy based upon what we heard in the clinical history. So just as Alex said, every single case today we're going to show is going to have the same IF pattern. This biopsy, while this was not the picture on the biopsy, did show C3 only staining. And on the right, I'm showing the electron microscopy. Let me orient you. This is a glomerular basement membrane. Here's another one. So this is the endothelial space. This is a neutrophil inside of the endothelial space. You can see some remnants of the fenestrated endothelium right here. So out here, then we have podocytes, and this is the urinary space. And along the outside of the glomerular basement membrane, we have these large, these are often called hump-like deposits. So those are subepithelial deposits because they're on the urinary, the outside of the glomerular basement membrane. If they are on this side, we would refer to them as subendothelial deposits. But proliferative glomerulonephritis, so summary, proliferative glomerulonephritis, C3 staining, hump-like deposits. This is a diffuse proliferative glomerulonephritis, classic for a post-infectious glomerulonephritis. Now, we don't commonly say post-infectious anymore. When we talk about infection, we tend to use the term infection-associated glomerulonephritis because commonly these patients still have ongoing infections. However, in this case, this patient's clinical history was consistent with a remote infection. So this is the classic post-infectious glomerulonephritis that you learned about probably in your medical school pathology class. And in fact, this is even consistent with that classic post-strep glomerulonephritis. Post-strep glomerulonephritis peaks in kids, usually, around the ages of 6 to 8. So the biopsy I've shown here is pretty classic, but you can see it in adults as well. A third of the cases are in patients more than 40. And in fact, in In our practice as a renal pathologist, we almost never see these biopsies from kids anymore because oftentimes the presentation clinically, it's evident what the diagnosis is. So it's more that the adults that end up getting biopsied. These patients commonly have gross hematuria. The cultures will oftentimes be negative at the time of the kidney presentation. So again, these are post-strep. About 75% of them will not have a positive culture. That's why these serologic tests, ASO and DNA-SPE, can be so helpful. ASO is more commonly seen in the patients with a pharyngitis, whereas the DNA-SPE is more commonly seen in patients with skin infections. So as you know, as most people know, complements are usually, the vast majority of the time, these patients are going to have hypocomplementemia. So I'll show you a biopsy from just to kind of illustrate the adult with a post-infectious glomerulonephritis. This was a classic diabetic type biopsy, actually. You can see here severe nodular mesangial expansion. So that's a Kimmel-Still-Wilson nodule. In this particular glomerulus, there's relatively little endocapillary proliferation, but most of the glomeruli look more like what I just showed you. So with lots of endocapillary neutrophils, hypercellularity, kind of the exudative glomerulonephritis. So this is the case of an adult, 55-year-old man with diabetes who developed a post-infectious glomerulonephritis. So again, this is that what Alex was describing as these collision cases. So these most of the time, again, we've got the classic picture on the boards. It's going to be IgG and C3. However, about a third of cases of post-strep glomerulonephritis will be C3 only. We hear that term, C3 only. That's a buzzword today for C3 glomerulonephritis. But in fact, C3 glomerulonephritis is a fairly rare disease in clinical practice, whereas infections are quite common. So I would say more often C3 only cases in practice end up being infection associated. IgA and C1q are typically negative. So your typical clinical course, these kids, this is a self-limiting disease. So typically these kids are going to resolve, they're going to do well, have complete recovery of renal function over a period of weeks. That said, monitoring them, they will have they will oftentimes have microscopic hematuria that persists for a long time after this. Notice I said typical clinical course. There are patients who don't behave this way. So let me show you the case of a patient who 2 years later still had hypocomplementemia, still had glomerulonephritis on the biopsy, had hematuria clinically. And now we're looking at the biopsy. While the biopsy looked more like the case I showed at the beginning initially, now we're looking at a biopsy that looks very different. This biopsy, in fact, looks almost a little more like that diabetic case that I showed. It's starting to become nodular with mesangial expansion. And this is the mesangial region. You see a tremendous amount of hypercellularity. In addition, the glomerular basement membranes have duplication. So this is a different pattern. I started with a pattern of a proliferative glomerulonephritis. When you have mesangial hypercellularity and glomerular basement membrane duplication, we now have a membranoproliferative pattern. Again, membranoproliferative is a buzzword that commonly gets mistaken for a disease. MPGN is not a disease, it's a pattern seen on the biopsy when you have mesangial hypercellularity and glomerular basement membrane duplication. So this is a great example of what's been referred to as an atypical post-infectious glomerulonephritis. So these biopsies will often look like an infection, a post-infection glomerulonephritis on the initial biopsy, but clinically they don't behave the right way. They don't have that self-limiting disease that quickly responds and goes back to normal. Rather, they have this persistent hematuria, hypocomplementemia, and decline in renal function. So this is an example of a conversion to a C3 glomerulonephritis. And the etiology of this ongoing disease is that these patients have an underlying defect in the regulation of alternative complement pathways. These can include, oftentimes they can be mutations in complement-related genes. It could also be antibodies. It could be more of an autoimmune disease where you have antibodies to different factors within the complement cascade, or antibodies to C3 convertase, so-called C3 nephritic factors. And I'll just finish this section with this recent study. It was a retrospective study, and it indicates that perhaps there might be a way to identify these patients with infection-associated glomerulonephritis who will have a typical versus an atypical course. And it specifically showed that greater than 90% of children with acute post-infectious glomerulonephritis, so the typical one, have overactivation of alternative complement pathways that's driven by transient autoantibodies to factor B. And that's what they're showing here. We have patients with acute post-infectious, GN, C3 glomerulonephritis, and then healthy control. So again, this is the level of factor B autoantibodies, and these patients with typical acute post-infectious glomerulonephritis have elevated anti-factor B antibodies compared to patients with C3G or healthy control. So the presence of these would indicate that this patient should follow a more typical course. Of course, this is not something that's available to my knowledge. Somebody can comment if they know differently. Not available in the clinic, readily available anyway. But perhaps we could have some help in the future with differentiating these patients at the time of the initial diagnosis. So that's a quick overview of infection-associated glomerulonephritis, with C3 only staining, and we can take a break here. If anybody has any questions, I can stop here and answer them, or if not, we've got plenty more cases to look at. We can keep going.
Hey, Chris, I have one question. One theme is coming up consistently. People are using post-infectious GN almost synonymously with infection-associated GN. So can you highlight why it is important to distinguish that and not use those terms interchangeably?
Yeah, sure. Thanks, Sri. So post-infectious glomerulonephritis is the classic name. It is the name that I learned in medical school and when I took my pathology course. That's what we called it. And it's still referred to commonly as post-infectious today. This was an example of a post-infectious case. This would be kind of the outlier today, though. Most of the biopsies, whereas most infection-associated glomerulonephritides were strep at one point in time, today, we more commonly see it in infection-associated glomerulonephritis in association with staph infections. That would be the most common. And most of the time, the patients still have a staph infection at the time of the biopsy. So rather than saying post-infectious, we say infection-associated because it's an ongoing infection. You're not past it yet. So in some ways, it's just being more correct, grammatically correct. But in other ways, we're really trying to indicate that the treatment for this glomerulonephritis is likely the treatment of that ongoing infection.
Okay, perfect. Thanks a lot, Chris. Yeah, you can move on to your next case. Yeah.
All right, let's go. So next case, 53-year-old. Skin rash, fever, acute kidney injury, proteinuria, as well as red blood cell CAS, has a positive ANCA, negative ANA, C3 is decreased, and C4 is normal. So let's go back to the microscope. Okay, here's a good view to illustrate what I'd like to show. I'm at a medium power. You can see here tubular epithelium. These are glomeruli, so we're in the cortex. The tubules are spaced apart. That's not normal. Tubules should be back to back to back. lots of edema here in the interstitium, as well as inflammation. But where we're really going to focus is here on the glomerulus. Very abnormal glomerulus. Going a little bit higher to see what's going on. And it becomes evident that here's the glomerular tuft, and it's being kind of pushed to the side by an epithelial proliferation outside. So this is on a PAS stain is what fibrin looks like. So this is a necrotizing lesion. These are cells. So this is a necrotizing cellular crescent. And we can see that most of the gloms in this field look this way. Let's see if there's any, don't really see any normal ones. I'll show you that on a Jones methenamine silver stain as well. I think it will help with highlighting those, the fibrin. Oh, this is good. This is a good glomerulus to look at because it illustrates something that Alex talked about early on, the immunofluorescence. Here's a glomerular basement membrane coming around. Oh, where'd it go? It just stopped. Here's the other side. So this just flapped open, and we have spilling out of the capillary lumen, this fibrin coming out into the capillary, into Bowman's space. Same thing over here, same thing over here. So again, this is a very active necrotizing crescent. There's another one. So most of these glomeruli are doing this, where we have the glomerular basement membrane breaks and cellular crescent formation. Let me see here. Are there any normal glomeruli I can kind of just juxtapose that with? Yeah, semi-normal one here. So here's what we want to see in a glomerulus. Capillary space. We have some red blood cells in the capillary lumens. That's normal. But here's mostly what we see. So we have a diffuse crescentic glomerulonephritis. Not surprisingly, this biopsy did show C3 staining. On the electron microscopy, again, we have glomerular basement membranes. I'm a little bit lower power this time, so you can see GBMs, urinary space. Here's the endocapillary space, and you see this red blood cell. Here are endothelial cells. You see the fenestrated endothelium well here. So this is the mesangium. No deposits along the basement membranes, but the mesangium does have some electron-dense deposits scattered throughout it. So just to summarize what we've seen in this case, we've got a crescentic glomerulonephritis. It's got some C3 staining, but no immunoglobulin. And it's a patient with a positive ANCA. So, what should we do here? I mean, we do have a positive ANCA. The crescentic fits really well with that. So should we just refer to this as an ANCA-associated glomerulonephritis? That's certainly in the differential diagnosis. However, this one had some things that made it a little bit unusual for ANCA. And the things that make it a little bit unusual is that the patient had hypocomplementemia. That's not typical in ANCA. And there was quite a lot of C3 deposition in the glomeruli on the biopsy as well. So in this case, rather than just going with ascribing or assigning this to an ANCA-associated glomerulonephritis, the differential of, as Sri said, infection-associated glomerulonephritis was risen. It was given back to the clinician. He said, great, I'm going to work this patient up. We're going to get infectious disease on board. Ultimately, an echocardiogram was performed, a vegetation was discovered, and the patient was found to have a Bartonella infection. And so this is actually an example of a crescentic glomerulonephritis that is an endocarditis-associated glomerulonephritis. So what is the histopathology of endocarditis-associated glomerulonephritis? And I'm talking about this separate because it is an infection-associated glomerulonephritis that doesn't typically have the classic light microscopy findings. In fact, this, here I'm showing a crescentic glomerulonephritis. In the middle, I'm showing an acute proliferative glomerulonephritis, the classic infection-associated glomerulonephritis. And on the right, I'm showing a mesangial expansion and hypercellularity. Just over half of cases of endocarditis-associated glomerulonephritis will be crescentic. It will have a crescentic pattern by light microscopy. So unless you're tuned into that, this could be something that could be easily missed. On the immunofluorescence, the most commonly the most common pattern is to see C3 staining. It's commonly C3 only, though IgM can also be positive, but usually IgG, IgA are negative in these cases. We had a small case series in which we found that ANCA being positive in these crescentic endocarditis-associated glomerulonephritis is not that uncommon. But, as you can see here, 3 out of 7 had ANCA positivity. Complements are usually they're oftentimes normal. So that's not always true that they have hypocomplementemia. And oftentimes the patients that we've seen in our practice will not have a diagnosis of endocarditis at the time of the biopsy. So again, it requires a high index of suspicion to do this workup to discover it. As far as the organisms involved, staph is most common. You can see a list of several others here, and it most commonly involves the tricuspid valve. There are some conditions that were associated with endocarditis-associated GN in our series. Probably the IV drug abuse and Hep C go hand in hand, but also, not surprisingly, patients with prosthetic cardiac valves and also patients with diabetes. So, we don't want to unnecessarily raise false alarms of infection every time we see a patient with crescentic glomerulonephritis. So the question really is, when should we raise this possibility? This is important to raise because if we think it might be the case, because the treatment is very different. I mean, if this is an infection-associated glomerulonephritis, this patient, rather than immunosuppression, which could be harmful, the patient needs probably treatment for the actual infection, so antibiotic therapy. So what we would say is that a crescentic glomerulonephritis pattern, I might raise the possibility of infection when I have some of these outliers. So in other words, the hypocomplementemia, as I said, that's not typical in ANCA. Not that it can't happen, it's just atypical. If we see strong staining by immunofluorescence, C3 or immunoglobulin, in the glomeruli that are not involved by crescents, and also if they have predisposing states, so they have IV drug abuse, they have a prosthetic cardiac valve, something like that. These are patients that it might be worthwhile just to be sure that when you have a crescentic glomerulonephritis on biopsy, you're not actually dealing with an endocarditis-associated glomerulonephritis. Okay, so again, I've got a little time, I built in a little time here for questions. I'm happy if anybody has anything to answer.
Chris, I have one question from that. So when do you raise a possibility of C3GN? Because these cases are showing you C3 deposits, you are raising a possibility of infection, but suppose clinically, if we ruled out infection, so when do you raise that possibility of C3GN in those cases?
Yes, exactly. And hopefully we'll get to that. The C3 glomerulonephritis, I don't mean to say it's not a real disease, it certainly is. And you can't base it too much on just the morphologic pattern. We can see C3 glomerulonephritis, that's crescentic. We can see it that has an MPGN pattern. So it is oftentimes, though, a diagnosis of exclusion, or if there are some tests you can do to look that are more that would be more that you would look to be positive. For instance, do they have any genetic mutations that are known to be associated with C3GN? Do they have any inhibitors of complement? So these types of things. But in general, I think it's fair to say that oftentimes it's not as easy as C3 only, C3GN. You've got to do the due diligence to exclude other possibilities before you make that diagnosis. So it's again, so much in renal pathology is a clinico-pathologic. We do our part, but that's one piece of the puzzle. The other piece of the puzzle and the problem solving comes on the clinician's part. So we're working hand in hand to get down to the actual underlying pathophysiology of this patient's disease.
Great. Can you all show us an example of C3GN, you or Alex?
Yeah, we've got some examples actually. You want to do that, Alex?
Oh, wow. That was amazing, Alex. You are ready.
Perfect segue to the next case. All right, so next case, we're gonna switch gears a little bit, slightly. There's a lot of overlap, but now we're gonna talk a 26-year-old female with really no past medical history who presents with nephrotic syndrome. The C3 was low, the C4 was normal. And let's go to the slides. So I'm going to start with a PAS stain. The PAS is really good for this pattern of glomerular injury. And even from this power, I hope everyone can appreciate that this is a very abnormal kidney. The gloms are very large and they're packed with cells. And then there's stuff in the interstitium that I'll get to in a second. So let's start with the glomeruli. So what is catching our eye here? Several things. First, the gloms are big, right? I mean, and they're big because there's a lot of cells in them, like I mentioned a second ago. Second, normally, it's really difficult to see the lobular architecture of the glomerulus, but not in this case. You know, so there's definitely, this is what we call accentuation of the lobular architecture. So that's one thing that raises or catches your eye here. Second, the mesangium, there's way too many nuclei. If you see 3 nuclei per mesangial region, that's already too many. And I mean, some of these are just packed with cells. So accentuation of lobular architecture, mesangial expansion with mesangial hypercellularity. Where are the capillary lumens? Well, there are some here, but in a lot of the segments of this glomerulus, you don't even see the lumen. What that means is that the lumen is completely packed with cells. In this case, it's mostly mononuclear cells, but we'll drive around and we may find other cell types within these capillary lumens. And lastly, where we can see them, the capillary loops are very thick. And I hope I can show you with other stains that there are some double contours. So we just covered the very classic definition of an MPGN pattern of glomerular injury, MPGN. Let's look at a different glomerulus. Okay. So in addition to everything we've just mentioned, there are these hot pink structures, which a lot of them are hyaline, but not all of them. Some of them, I'll try to prove that they are deposits. You know, you see this very pink, hot pink refractile material. When we go to the silver stain, you'll see that these stains, these structures will be weakly or non-argyrophilic. In other stains, they will not stain with a silver-based stain. And that's a very classic characteristic of deposits. Now, remember, we mentioned that most of the cells were mononuclear, you know, one nucleus, that it's reniform with abundant cytoplasm, but you have areas that we start seeing more segmented, you know, neutrophils here. All right, so very classic MPGN pattern of injury. Let's put on hold the glomeruli. And what is this? What's happening with this interstitium? Anyone has a clue? Is this an Alport? You know, and the reason why I mentioned it is because a very common test question for Alport is that they show you interstitial foam cells, which is what we have here. I'm just trying to make a point, and this is not even the reason why I chose this case. These cells just happen to be there. But we always try to tell people, interstitial foam cells, the only thing that means is that this patient has had proteinuria for a very long time. And you can see it in membranous, you can see it definitely in Alport, which is where it was, you know, very classically described. But, you know, even in cases like this, that you have numerous interstitial foam cells, it just speaks of severe and prolonged proteinuria. Let's retake our long description for a second. So I hope I made the point clear that this is an MPGN pattern of staining, but the Jones stain, MPGN pattern of injury, but the Jones stain really helps you to identify the deposits. MPGN, although usually has deposits, it does not always have deposits. You can have pauci-immune forms of MPGN. But here you see all this pink material. Those are deposits in the capillary loops. So the Jones stain is very good in staining the basement membranes, but is very bad in staining the deposits. So all this pink stuff with rarefaction of the capillary loops is a negative image of all the deposits that are there in the capillary lumens. And let me try to find an area with double contours. I mean, they're everywhere. I just want to find so we have areas like here or here where you see the double contour formation of the capillary loops. So we have a MPGN pattern of staining with a lot of deposits by light microscopy. Now let's go to the immunofluorescence. Same C3, picture that we've been using, but the electron microscopy is, in a way different, but it also has similarities to what Chris showed. So we still have the subepithelial hump-like deposits. The density of these deposits is a little bit darker than the matrix and the basement membrane, but it's not terribly dark like we see in other areas here. But in addition to the subepithelial hump-like deposits, we have numerous intramembranous and mesangial deposits. We see new basement membrane formation. So this loop is packed with deposits. This is another area of the same glomerulus where we see the abundant mesangial deposits. We also see subendothelial widening with some endothelial deposits and new basement membrane formation. So this, again, it's the lumen of the capillary. This is the urinary space. This is the original basement membrane, and you're starting to deposit neomembrane here. And again, all these dark deposits are the C3 deposits, large subendothelial deposits as well. So because it's so MPGN and with the history, we can say in this case that this is a C3 glomerulonephritis. Since there's overlap with what Chris presented, if you tell me this patient has a shunt, or has a chronic infection of some sort, could this be a chronic infection? Absolutely, absolutely. And again, we need to do clinical pathological correlation to really make this diagnosis. But in a young patient with no history, with such a florid MPGN pattern, and the massive amount of deposits in the glomeruli, then the likelihood of this being a C3G significantly increases. And in this case, we know that there was no history of infection, et cetera. So we can certainly make that diagnosis. So C3GN or C3 glomerulonephritis, it's part of a group of diseases. The umbrella term is C3 glomerulopathies. And the two main diseases that are included in this umbrella term is C3 glomerulonephritis and dense deposits disease. There are other, genetic or hereditary diseases, and the atypical acute glomerulonephritis that Chris really nicely talked about. But the main two diseases that we'll find under this designation is C3GN and dense deposits disease. And there's really a lot of overlap among these diseases. The thing that is in common in all of these diseases is that they have dysregulation of the alternative pathway of complement activation. They all have C3 deposits in the mesangium, and they all have electron deposits by electron microscopy. We've talked about this already quite a bit. All right, I'll take 30 seconds, maybe 40 seconds on this slide. First, in the interest of time, but second, I really cannot look at a complement cascade for more than 30 seconds without getting dizzy and a little bit nauseous. So I won't spend time on this. The only point I want to make is, unlike the classical and lectin pathways, where you need something that activates them, the alternative pathway of complement is continuously being activated by this tick over phenomenon, right? Hydrolysis and activation. But why do most of us don't get disease? Well, that's because we have an amazing way of regulating this pathway by regulatory proteins and factors. So the complement is really good about auto-regulating itself so it doesn't go bananas, right? Which is what happens with these patients. Now, there are situations, either autoimmune phenomena, meaning autoantibodies against some of these components, or genetic mutations that really affect the regulatory capacity of the alternative pathway. And then you have a massive activation of the cascade, and everything downstream gets activated. So around 50% of patients with C3G have antibodies against the C3 convertase. This is what we call the nephritic factor. So about roughly 50% of these patients have nephritic factor, but they can also have autoantibodies against factor B, factor H, factor H, and mutations in factor I, factor H, C3, etc. So this is just to show that there is an abnormality of the regulation, not so much the activation, but the regulation of the alternative pathway of complement. And really what happens is that the more convertase that you have, the more C3 you produce, and then at the same time, the C3b produces more or becomes more or enhances its ability to cleave C3, and then the loop continues and continues and continues. That's why we're seeing so much C3 on these patients. The most classic pattern of glomerular injury, like I showed you, is MPGN, but a good number of cases show only mesangial hypercellularity, especially at the beginning of the disease. You can also have proliferative and crescentic variants. And even the cases that are not floridly crescentic, frequently these cases like MPGN or any of the other patterns will have crescents here and there. Just keep in mind that if you have a proliferative pattern with C3 only, we're almost really talking about the same thing that Chris talked about. The pattern can be very, very similar. That's why there's so much overlap. And again, once again, I know we've mentioned this a lot. That's why we really need the clinical part to make this diagnosis. Now, I want to take the opportunity to kind of emphasize what Chris said. MPGN, it's not a disease. MPGN is not a disease. MPGN, it's a pattern of disease. And actually, if you go back and look at all the diagnoses that have been called MPGN type 1 or MPGN type 3, a significant proportion of them would now be called C3GN, all right, or DDD. So for that reason, really, we shouldn't be making a diagnosis of MPGN anymore. If we make a diagnosis of MPGN, I'm not telling you anything as a clinician. I'm just giving you a pattern. So it's really helpful to first divide them. Is this MPGN having immune complexes or just complement? If they have immune complexes, then obviously there's a differential. We can be talking about lupus, chronic infections, monoclonal gammopathies, etc. If they don't, if it's a purely complement-mediated disease, then you have two options, basically, DDD or C3G, unless there's like family history, which, there are other mutations, but at the end, they're variants of C3G with a strong genetic component. But basically, that's how we should look at MPGN in 2021. So even though we keep saying that it can be C3 only, it doesn't have to be C3 only. As long as it's C3 dominant or predominant, it's good enough to make a diagnosis. And the strict definition is you need to have 2 orders of magnitude C3 above any of the other immunoreactants. So let's say you can have a 1+ IgM and a 3+ C3. Yeah, that's meeting criteria for C3. That's okay. So a little bit of immune complex deposits, it's okay. In fact, you can, if you have more deposits, it potentially could still be C3G. The only problem is that in those cases, we have no way to diagnose them currently with pure pathology. Like if a patient has underlying defects of the alternative pathway or complement and they get an infection or they get lupus or they get an IgA, a lot of these immune-mediated process, part of what's driving the disease or prolonging the disease are alternative pathway complement defects. But again, right now, we have no way to prove that. That's why to err on the side of specificity rather than sensitivity, then we only really suggest the diagnosis of C3 when we have at least 2 orders of magnitude in the difference of C3 versus the other immunoreactants. But you can have humps identical to the ones you see with infection. So really, the presence or absence of humps makes no difference. And you can have really deposits in any portion of the glomerulus, in the loops, so epithelial, subendothelial, intramembranous, mesangial, it doesn't matter. and there's a spectrum. They can be more waxy looking, they can be darker, as long as they're very, very dark, because then you may be dealing with a DDD that we're gonna talk about soon. I'm not gonna talk about this again, but there's definitely an overlap. So you have infection-associated on one side, C3G on the other, and then there's this gray area where you can have, Chris talked about this, where you can have infection with some abnormalities, which some are transient and some are not. I do want to make a point though, before we move on. Statistically, if you look at all the C3Gs in patients over 50, depending on the series that you read, at least 60, sometimes even 80% of these patients have detectable monoclonal immunoglobulins. It could be an Mgrs, it could be a lymphoma, it could be myeloma, but 60 to 80%, that's a lot. That you cannot argue that that's normal. I mean, if you take all general population over 50, I guarantee that 80% of them will not have an Mgrs. This is disproportionate. So there are cases where we can prove that the monoclonal immunoglobulin, it's affecting the complement pathway. There's reports of autoantibodies against factor H. There's reports of monoclonal immunoglobulins acting as nephritic factors. But the truth is that in most of these patients, you will not be able to prove that. But there is data, especially from the French group, that even without proving it, if you give clone-based therapy to these patients, they do better. All right. So nowadays, and this is a completely different branch of renal pathology and nephrology, the whole MGRS world, now C3G in adults over 50 are considered MGRS lesions for that purpose, for that reason. So anyway, things to remember. Not everything with C3 is C3G. Please, this is probably the most important thing. And I think this gets overcalled quite a bit. Second, the fact that there are immunoglobulins doesn't rule out C3. That's also very important. MPGN is not a disease, it's a pattern. You need to rule out infections before we make a diagnosis of C3G. Never make this diagnosis without paraffin IF, and we haven't explained why, but Chris will talk about that in a minute. And you have to rule out monoclonal immunoglobulins in older patients. All right. Next case, 18-year-old female. Again, no past medical. Oh, sorry, Shri, are there any questions that you want to talk about, or should we move on?
No, Alex, we didn't have any questions, but your last slide was very pertinent, because before your lecture, like whenever as a fellow we see C3, C3GN is always coming to our mind, right, as a fellow, and it is very difficult to think beyond C3. So the slide which you have put up as a summary is very, very important. Yeah.
Okay, the next case, again, a young female, no past medical history. Typical story, by the time we get the biopsy, frequently the serologies are still pending. So frequently we're working a little bit in the dark in that regard. But the patient did have nephrotic range proteinuria and hypertension. So let's go to the case. And I will show you, in the interest of time, I'll show you two different cases that have the same diagnosis. That way you can appreciate the heterogeneity of the light microscopy on these cases. So this is the first case. And again, the foam cells that we were talking about on the other case, I promise it's a different case. But the morphology, maybe not as dramatic, but it's similar, right, to what we were talking with C3G. There is a little bit of accentuation of lobular architecture. There's definitely mesangial and endocapillary hypercellularity. At least this glomerulus shows a little bit more neutrophils than we appreciated on the previous one. But at the end, we're still going to be talking about an MPGN pattern of injury. We have some double contours there. So less dramatic, but still an MPGN. All right, I hope you can appreciate that. Let me show you the Jones. So let's focus for a second in the mesangium. The mesangial matrix should stain very dark on silver stain. It's very argyrophilic. And you can see that in this case, it looks quite pink. The pink is the Cantor stain that we use for the Jones. So that means there is deposition of material of some sort. We still don't know what it is, or we do because of the theme. But there's something definitely on the mesangium, and there's something definitely on the capillary loops. You see how mottled and irregular and rarefied this loops are. And here you have a nice double contour. And obviously we can appreciate the endocapillary hypercellularity. So, it looks fairly similar to the previous case. But let me show you this other one. It becomes a little bit more interesting because this is a much milder variant of the disease. Here, we're not really appreciating the endocapillary hypercellularity. This is clearly not an MPGN pattern. But if you go down, or I should say up or higher power, you see that the capillary loops are not normal. You have what looks like a string of beads, with this eosinophil, PAS positive refractile material. You see here, it's thickening the basement membranes and it's very, very PAS positive. Here you see more. I hope you can appreciate it here. You can see it here. Let me find real quick a second glomerulus. You see this? This is a more normal looking loop compared to this one. It's very hot pink and thick, but it's segmental. It's not affecting every loop or the whole circumference of the loop. Let's look real quick at the same lesion under H&E. I'll find the same glomerulus. And again, I hope you can appreciate how thick these capillary loops are. And this material or this morphology that I was describing under H&E, it's eosinophilic and it looks very glassy, kind of refractile. All right. So if we look at the immunofluorescence, obviously, continuing the theme, it's C3 only. But when we get to the electron microscopy, it's a very different picture, right? Here, what do we have? We have almost complete replacement or transformation of the basement membranes, electron dense transformation of the basement membranes that are segmental, and they start thin and then they get thicker and it expands the basement membrane. And then you have areas that are more normal. And again, you see these very dark deposits or very dark transformation of the lamina densa. And here you have it, and it alternates. You can have some deposits, but it's not as impressive as what we saw with the C3G. Let's look at a higher power, and then you have complete transformation of the basement membrane on this loop. So you could argue that up until the electron microscopy, the case looked identical to a C3G case. But in this case, it's a dense deposit disease. And I mentioned earlier, because these deposits, the pathophysiology is so similar, there's a lot of overlap among them. They're both C3 glomerulopathies. Again, 10 more seconds of compliments. That's as much as I can handle for the day. But I do want to make one difference though, jokes aside. I mentioned that on C3G, about 50% of the patients had nephritic factors. Well, with dense deposit disease, up to 80% of patients have nephritic factor. In fact, if you just look at the pediatric population, close to 100%. Almost all kids with dense deposit disease have nephritic factors. Again, you can have autoantibodies to factor B, factor H, and genetic causes that stabilizes certain or affects the function of certain complement factors. But really the big thing in dense deposit disease is the presence of nephritic factor. It gets interesting. If you remember, dense deposit disease used to be called type 2 MPGN, all right? But look at this slide. Less than half of the case, the majority of the cases are not MPGN. So how can you call something MPGN type 2 when the majority of cases are not even MPGN? That's why we completely discourage everyone to use that terms nowadays. And the name of this disease is dense deposit disease, all right? You can have a mesandoproliferative like the second case I showed. You can have an MPGN like the first case I showed. And there's also, again, crescentic and proliferative variant, endocapillary proliferative variant. This lacy refractile thickening of the capillary loops is very characteristic. And again, it stains weakly positive on Jones stain. The immunofluorescence can have different patterns. It could be granular, it can be lineogranular, it can be like this, what I'm trying to show here. It can form rings. These are the famous mesangial rings of DDD. Now, this was first published in the late 70s. This picture is not from that paper. That paper is in black and white, and I'm using a different image from Dr. Walker's paper. But basically, not infrequently in these patients, you not only have granular mesangial deposits, you can have rings or like little donuts where you can have a negative image in the center with positive staining in the periphery. The same thing, you can see it in the capillary loops. It looks like tram tracks or railroad tracks where you can have staining, negative staining, and positive staining. Of course, we're very used to seeing that on light microscopy. That's what we call double contours, but we're not really used to seeing that on IF. That doesn't happen with a lot of diseases. It's very interesting. When you see it, really, we start thinking DDD. Now, there was, in this paper that I'm referencing, the one from the 70s from Dr. Kim, he made really fancy studies. He showed that the C3 is not present throughout the transformation of the basement membrane. He said, or he thought it was only present at the margins of the dense deposits. This concept has been challenged and probably disproven not too long ago, where other groups have shown that there's C3C in the deposits, but for the longest time, it was a very intriguing and interesting phenomenon. Now, even though the same thing we discussed about the IF on C3 applies here, the fact that it has to be C3 dominant, the fact that you can have a little bit of immunoglobulins, rarely you can have a lot of C1q and C4, all that identical to what we describe in C3. I'm just going to take the opportunity to mention this, and this also happens with C3. Patients that get treated with eculizumab and get rebiopsied, when a biopsy was initially negative for IgG kappa and lambda, subsequent biopsies or post-treatment biopsies can have G kappa deposits that are IgG2 and IgG4 restricted. What is this? Did the patient suddenly develop a monoclonal immunoglobulin? Unlikely. What we're seeing is the eculizumab in the tissue. I think this is really cool and really fascinating. Eculizumab is it's a hybrid immunoglobulin that has parts of IgG2 and parts of IgG4 kappa, and that's exactly what we see. We see an IgG2 and IgG4 kappa restricted staining, and we see it in the same pattern that we see the C3. And I forgot to mention this, but on DDD, the deposits are not only limited to the capillary loops or the mesangium. You can have Bowman's capsule, tubular basement membrane deposits, and this is exactly the same thing that we can see on immunofluorescence post-treatment. So if you ever get a diagnosis of de novo or post-treatment monoclonal like MIDD, question that diagnosis, because very likely you're seeing the eculizumab. This is a nicer EM of DDD. The other one that I showed is the recent case. This is, a more classic morphology where the dense transformation of the base membranes look like sausages. Look at this. This looks like a sausage. It's thinner here, thicker here, and it becomes thin. And it's very segmental, really. That's very characteristic of DDD. It's not every loop and the whole circumference of the loop. It's segmental and segmental even within a single loop. All right. It's discontinuous, in other words. You can have humps as well, subepithelial deposits. So that doesn't change anything. Yeah, and I think that's all I have for DDD. Shri, I don't know if there are any questions.
One question, Alex. How important is EM in making this diagnosis? Because we have few attendees and in their centers, there is no EM. So what is the importance of EM as well as paraffin IF was also raised in making a diagnosis of C3G?
Okay, let's start with the EM. It's depends on how you want to see it. How important is EM to make diagnosis of DDD? Well, it's essential. You really cannot make it without the EM. You can suggest it if you see that lacy pattern of the capillary loops, that's suspicious. But the the disease is really defined by the electron microscopy. So you could argue without EM, you cannot make the diagnosis. Is it important always to reach a definitive diagnosis? Well, for practical purposes, maybe not so much. It's good to do it, but at the same time, and maybe with time this changes, but probably the main management and the idea of C3G and DDD are similar, right? I mean, there are differences in age, mean age at presentation, the risk of recurrence in the allograft, what specific mutations are more common or not. But at the end, the vast majority of cases, there's tremendous overlap in terms of clinical presentation, prognosis, treatment, et cetera. So if you don't have the EM, and if you treat it as a C3G, probably at the end, it's not going to be a huge difference. But in terms of making the best possible diagnosis, you definitely need EM. And then regarding the paraffin IF, let me leave that on hold, Shri.
Okay.
Because on the next two cases, Chris will talk about that. So let's hold off on that.
Sure. Thanks. Chris, back to you.
Thank you. My screen going. Okay. Let's jump right in another case. This is a biopsy that I read a few years ago. It was the very first patient that I ever saw with the disease that I'm going to show now. A 17-year-old girl who had about 3 grams of proteinuria, had recently been treated with IVIG for ITP. Other than that, the serologic studies were negative, complements were normal. So biopsy was received. And this is what we saw. We look from here, not surprisingly, based on that normal serum creatinine, the tubular interstitium looks relatively normal. Tubules are back to back to back. This is what you want to see. You do see some of what Alex described in the last session, these interstitial foam cells, indicating that she has had long-standing proteinuria. But when we go down and look at the glomeruli, we notice that these do not look normal. There is, especially for such a young lady, there's mesangial expansion. The glomeruli have very prominent basement membranes, very PAS positive material everywhere. And if we want to further characterize that, we can quickly look at a Jones stain. And we'll be able to see kind of what's going on here. Is this, an MPGN pattern? At first glance, it kind of looks like that, but if we really look closely, I think you can appreciate that there's some eosinophilic material that sits on top of or outside of the glomerular basement membranes in most of these glomeruli. And there's kind of almost shaggy-like spike formation in a lot of the areas as well. So it's very unusual. Again, here's some of that. Here you see these kind of spikes forming along here. So somewhat more like a membranous appearance. So this is what we see on the light microscopy. Immunofluorescence, though, showed that C3 staining, no immunoglobulin. So this was confusing when I first saw it. It looks like a membranous. It has the presentation kind of like a membranous, but it doesn't have the immunoglobulin staining. So in this case, paraffin immunofluorescence was performed. Again, this is, Alex described this briefly at the beginning, but if you weren't with us, this is immunofluorescence that is performed on that formalin-fixed paraffin embedded tissue after protease digestion. And what we see is while all the immunoglobulins were negative by routine IF, when we get to the paraffin immunofluorescence, we have positivity and a pattern like we would expect based on the light microscopy for IgG and for kappa, but not for lambda. So IgG kappa staining, that unmasks. We talk about unmasking. All that really means is false negative staining on the routine immunofluorescence. So we get to the electron microscopy and see more clearly what we were seeing by light microscopy. Here's a glomerular basement membrane, mesangial region, red blood cells, podocytes, large deposits sitting on the subepithelial aspect of the glomerular basement membrane. So here they are. Even some of them you might say have a hump-like configuration. It's not uncommon to find that. So what's going on here? Well, this is a good and classic example of an entity that developed a very long name. It's known as membranous-like glomerulopathy with masked IgG kappa deposits. So it is a very descriptive diagnosis, but it actually describes what it appears to be a unique entity rather than just a pattern. In this case series of patients with these findings on the biopsy, we took a consecutive case series of patients with membranous-like glomerulopathy with masked IgG kappa deposits. There were 41 of them, and found that if you just want to quickly summarize it, these patients are relatively young. In fact, almost 90% are younger than 40, mostly female, usually present with proteinuria and hematuria, so somewhat like an IgA nephropathy, but they commonly have a positive ANA. It's usually a low titer positive. While they often have an ANA, they oftentimes don't have a diagnosis of lupus. Sometimes they'll have other autoimmune phenomena. Like I just showed you in this biopsy, this patient had ITP. So complements are usually normal, and this is important at the bottom. While this shows light chain restriction on the biopsy, the vast majority do not have associated hematologic malignancies or positivity for M spikes on SPEP. So this is not a monoclonal gammopathy of renal significance. The light microscopy, I showed you the classic picture, but you can also have other patterns as well. I'll just quickly show a couple more cases to show a little bit of the disease diversity, the spectrum. So here we have a biopsy that most of the glomeruli look relatively normal by light microscopy, but occasionally you have you have FSGS lesions, otherwise normal. There you do have those interstitial foam cells again. Now notice that. And other times, so that would be kind of an FSGS pattern. Other times you're going to see changes like this. I showed this earlier. This is cellular crescent. This is crescent formation. This is probably more of a fibrocellular crescent. Here again, crescent formation in these glomeruli. So if we look at the case series I was describing, these patients have this kind of normal, typical, just membranous type pattern by light microscopy about half of the time. Sometimes they'll have mesangial hypercellularity. About 15% will have an FSGS pattern, but then almost 20% will have a crescentic glomerulonephritis on the biopsy. What really hinges this what really clutches this diagnosis is the immunofluorescence, though. And again, this is from the case series I was telling you about. I want you to pay attention to this. This is immunofluorescence on the frozen tissue, paraffin immunofluorescence on the right. So routine frozen immunofluorescence. Immunoglobulins are negative in most cases. When they're positive, they're weakly positive. But if we compare the frozen immunofluorescence and the paraffin immunofluorescence, you see this dramatic change in patients, and these patients for IgG and kappa. You see everything else stays about the same, but the IgG and kappa unmask with the paraffin immunofluorescence. And it should be noted that C3 was common in these patients on routine immunofluorescence. So they could easily be misdiagnosed as C3 glomerulonephritis if the paraffin immunofluorescence is not performed. A small update to this entity is that More recently, we found by microdissecting glomeruli from this entity and comparing it to other forms of membranous, that the protein SAP, Siri just told me she doesn't understand, which I'm not surprised. I'm not sure I understand either. But SAP was an outlier. This is serum amyloid P, along with several other complements, were significantly increased in the glomeruli from this entity of membranous-like glomerulopathy with masked IgG kappa deposits. Ugh, get tired just saying that long name. So SAP is positive. Let's just skip to this, MGMID in this entity and co-localized with IgG, but it did not stain positive in other types of membranous. So today we use this as a biomarker in cases. We don't do all the co-localization, but if it's positive, that's a confirmatory test of this entity. So quick update. Young females frequently have kind of vague autoimmune phenomena. They'll have monotypic deposits by paraffin immunofluorescence, but don't have evidence of an associated monoclonal immunoglobulin, so it's not an Mgrs. Usually don't have endocapillary proliferation, though they can oftentimes have crescent formation, and these are SAP positive. So again, just another example of a disease that's in the differential diagnosis when we see routine immunofluorescence C3 only staining. It's an esoteric disease. Many of you, you may never see that in your clinic, especially if you don't treat a lot of pediatric patients. But nevertheless, it illustrates the point that when we see this C3 only staining, we're working with a differential diagnosis. So I'm happy to answer a couple of questions if there are any.
So Chris, your case, this one highlights the importance of paraffin immunofluorescence, like performing immunofluorescence on the paraffin tissue. So how often do you do paraffin immunofluorescence? Like, what is your indication? When do you do it? Like, how did you suspect, in this case, this is a triple MG rather than like just a C3GN? So how do you handle those cases?
Yes, exactly. Well, so in cases that I would otherwise call C3 glomerulonephritis, again, I talked about that earlier being a diagnosis of exclusion. And one of the things I would like to do, especially in an older patient, one of the things I would like to do would be to do paraffin immunofluorescence to exclude immunoglobulin unmasking by paraffin IF. So in cases of C3GN, I'll commonly do it. There are just known kind of pitfalls with routine IF that you become aware of in clinical practice. Alex, if you want to go back to his slides at the beginning, if you're watching this later, you can see that slide that he showed from one of Sami Nasser's review articles where he talks about diseases that are more sensitive with routine and immunofluorescence, and then ones that are more sensitive with paraffin immunofluorescence. And so you kind of just learn to be aware of which diseases you need to do this in. But oftentimes it's just everything's not adding up. For instance, this case, I had what looked like a membranous pattern, but I wasn't seeing immunoglobulin staining. That does not make sense. A membranous pattern should have immunoglobulin staining. So I'm going to do paraffin immunofluorescence just to make sure. Cases of C3GN, I've already said. Light chain crystals, light chain proximal tubulopathy with crystal formation will frequently be masked. So you learn the different areas where it can be helpful and,
Got it. 2 more questions popped up, Chris.
Sure.
How will you differentiate this entity from Mgrs and proliferative glomerulonephritis with monoclonal immunoglobulin deposit?
Yeah. So you notice this did not have endocapillary proliferation. It did not have an MPGN pattern. And it also did not stain for by immunofluorescence on routine immunofluorescence for any immunoglobulins. So, and it also, this is called membranous-like for a reason. Most of the time they are membranous-like. They have subepithelial deposits. So those are the big differences. PGM and ID, what I call Nasser disease, that is a disease that stains by routine immunofluorescence. You don't need to unmask that. And the other
you think
one,
SAP is helpful? SAP is helpful
SAP,
in different.
yeah, SAP could certainly be helpful as well. Yeah.
Okay, perfect. Thanks a lot, Chris.
Yeah,
that was all. Yeah.
Okay, great. Well, let's go on.
Mhm.
Okay, new case. 68-year-old man has nephrotic range proteinuria and acute kidney injury. Baseline, not normal though, has CKD3. Serum creatinine is now 6, has nephrotic range proteinuria. And you can see the past medical history. He has a known M spike. So biopsies performed to further investigate the etiology of this change in renal function. And here's what we see. It's a good glomerulus to start with. This is a PAS stain. At first glance, that looks like what I showed you with diabetes, right? Kind of had nodular mesangial expansion, but again, lots of hypercellularity in those mesangial regions. I mean, this mesangial region has, more than 10 mesangial nuclei. That's way too many. So mesangial hypercellularity, glomerular basement membrane duplication is also present in this case. So we've talked about this a lot. This is an MPGN pattern, right? I'll show you the Jones methenamine silver stain because it's always so pretty in these cases. It's hard to not take a lot of pictures of it when we see these in our practice. So again, you see these mesangial regions highlight, and then the glomerular basement membranes have duplication as well. So, and you can also appreciate that the endocapillary spaces are filled with cells. That's another common feature in an MPGN pattern, especially when it's a really active MPGN. So that's our light microscopy. We got that history of a man with an M spike. We now have our light microscopy of an MPGN pattern, and our immunofluorescence. Not surprisingly, it's going to show C3 only staining. This time, paraffin immunofluorescence is performed. And again, very similar to last time, we have, while IgG was negative on the routine frozen immunofluorescence, it's now positive. You see it staining along the capillary loops. It matches the kappa, but the lambda is negative. It does not unmask. So unmasking for IgG and kappa. So the diagnosis, we get to a diagnosis here. I'm sorry, I forgot to put in an EM on this one. But the diagnosis is a membranoproliferative pattern of glomerulonephritis with a masked monotypic IgG kappa deposit. So I'll go quickly through a recent, or not that recent now, 2015 case series that looked at 16 patients with this exact pattern. These patients presented very similar to what I just showed with this case, where they have renal insufficiency, oftentimes nephrotic range proteinuria, hematuria, and 2/3 of them will have hypocomplementemia. The unmasking, what I showed was the most common, IgG kappa, followed by IgG lambda, but much less. And then sometimes in this series, the heavy chain was IgM. Coincidentally, yesterday, I had a case of this come across just in my routine clinical practice. That was IgG lambda, so that does happen. Oh, important to point out, 2/3 of cases showed C3 only staining by immunofluorescence. Okay, so again, they would have been very worrisome and easily misdiagnosed as C3 glomerulonephritis if the paraffin immunofluorescence had not been performed. So as a part of this study, we also looked at 29 total cases in adults of C3 glomerulonephritis, or I shouldn't say C3GN, I should say C3 only staining with an MPGN pattern by light microscopy in adults older than 40. Now, 6 of these, based on the electron microscopy, and we just saw what that looks like, were dense deposit disease, and 23 were C3 glomerulonephritis. And we performed paraffin immunofluorescence on this cohort in order to learn how commonly, when you have this scenario of C3 only MPGN in an adult. How common is it to unmask something? Well, if you just look at the DDD cases, the dense deposit disease cases, it never happens. So for that reason, I don't normally recommend that. There's a lot of utility in attempting paraffin immunofluorescence in what you would call a dense deposit disease if you have the ability to do EM. None of them unmasked anything. However, in these 23 cases of MPGN with C3 only staining in adults, about 40% unmasked. So not quite half, but getting close. So for this reason, and I think some people have brought this up in the comments, for this reason, we often recommend that C3GN be a diagnosis of exclusion, particularly in adults, only after we've evaluated for masked deposits by paraffin immunofluorescence. Back to those 16 patients in the case series. Most of them had a monoclonal immunoglobulin on their SPEP that matched what we were seeing on the biopsy. So, MGRS lesion and the accompanying finding on the serum protein electrophoresis. There were 2 cases that were negative for any M spike, but both of those had a clonal B cell population detected on the bone marrow biopsy. So all of these, really, all 16 of the cases had an identifiable clone or a monoclonal immunoglobulin. 100% of these truly had probably an underlying clonal process driving them. As far as what did we see on the bone marrow biopsy? Well, 13 of the bone marrow biopsies were abnormal. 9 of them had a plasma cell dyscrasia, though it was typically a very low grade neoplasm with less than 10% monoclonal plasma cells. And then 4 of them had clonal B cell populations. So that included a mixture of different types. Okay, so that is that lesion, and I think it illustrates well some of the questions that have come up about when should we unmask and what could you find when you unmask and things like that. So I'm happy to answer any questions if there are any.
This was very helpful, Chris. So basically, unmasking helps us identify a subset of cases in which underlying lymphoproliferative disorder is present. The chances are very high in this subgroup of patients, right?
That's right. That's correct.
Yeah.
Unmasking, when you have an MPGN pattern and you unmask a monotypic immunoglobulin, the vast majority of the time, there will be some underlying neoplasm driving that. Now that is compare that with PGN-MID, proliferative glomerulonephritis with monoclonal IgG deposits, AKA Nassau disease. PGN-MID is considered to be an MGRS lesion, but, and again, let me just back up. When I say PGN-MID, I mean ones that you don't have to unmask. Most of the time, those will not have an accompanying identifiable clonal process. Only 30% of the time will they have an identifiable clone. So when you detect a monotypic deposit that you have to unmask, it's much more likely to have an associated clone than if you detect it on the routine IF. I hope that makes sense.
No, this perfectly makes sense. This was very helpful, Chris. Thank you. We have 15 minutes. We have time for one short case. So any one of you can go ahead and present.
Oh, let me stop sharing. You got something? Do you have anything, Alex?
Yeah, I have one more, and I'll do it real quick.
Yeah, we have 15 minutes. Yeah. Thank you.
Okay. Okay. So just to recap, before I show the case, we've done 6 different diseases on the differential diagnosis of C3 only. We've done infectious RGN, we've done endocarditis, we've done C3G, we've done DDD, membranous-like glomerulopathy with masked IgG kappa deposits, and MPGN with masked IgG kappa. This is the 7th thing in the differential. And with this, pretty much we can cover the differential diagnosis of C3 only diseases. This is almost an instant pattern recognition, so I will not spend too much time on the morphology for two reasons. We've talked like way too much about MPGN in a single day, so we no need to go through the pattern again. And the other is that in this particular case, which this is a very recent case actually, it's really dramatic, the finding. In addition to the MPGN, you see this abundant endocapillary hyaline thrombi or pseudothrombi that they're definitely not hard to find. I hope you can appreciate them. All these PAS positive structures within the lumen of the capillary loops. So that, and you know, here's another one. So a lot of mononuclear cells with ample cytoplasm. You do have deposits in the capillary loops as well, and they're not hard to find. But really, what catches your eye are those endocapillary thrombi, and the trichrome stain actually brings them. These deposits are very fusionophilic. So if you look at this, this is beautiful. Sorry, I'm a pathologist, so I get very excited about this. But you see how red this is. This is strongly fusionophilic. And even if you had missed them on the PAS, really, the trichrome brings them out. That specific lung had a lot of kind of like wire loops, big subendothelial deposits, but this other one has a lot more of the endocapillary hyaline thrombi. And let me show you real quick one more, just so you can appreciate it. Look how pretty this is. All right, so I hope you know where I'm going to with this last case. Let me switch back here. Oh, and I never gave the history. This is a 60-year-old with CLL, hematuria, and proteinuria. Same IF. I did paraffin immunofluorescence, and once again, we unmasked an M kappa, which was staining in the capillary loops, but also in the hyaline thrombi and in the mesangium. IgG and lambda was completely negative. The immunofluorescence showed big subendothelial deposits, which you can even from this power see a vague substructure. You know, they don't look homogeneous. They look like the deposits have some structure to it. So this is a very classic case of type 1 cryo. I was going to show another case, but let me skip it so we can get to the discussion. Basically, the morphology you can use the same morphology for a type 2 cryo, but in this case, instead of being IgM kappa deposits like in the previous, you can have a more more staining with IgG, IgM, kappa, and lambda, and we're going to talk about this in 1 second, so bear with me. So when we say cryoglobal anemia, we're talking about the presence of immunoglobulins that at 37 degrees, so in vivo, they dissolve, they're soluble, but in the lab, in vitro, when you put them at 4 degrees, they agglutinate. This is the definition of cryoglobulins. So when you have cryoglobulins in the blood, you have cryoglobal anemia. When you have cryoglobulins affecting the tissue, we typically say that there's a cryoglobulonemic vasculitis or cryoglobulonemic glomerulonephritis. So for a long time, we've classified cryoglobulins into 3 types: type 1, type 2, type 3. Type 1 is a monoclonal immunoglobulin, period. It's a monoclonal immunoglobulin that if you cool it to 4 degrees, it agglutinates. That's the definition of type 1 cryo. Type 2 and type 3 cryos are a little bit more interesting. Type 2 cryo, it's a monoclonal immunoglobulin, typically a monoclonal IgM, that it's directed against the Fc portion of a polyclonal IgG. This is what we call a rheumatoid factor properties. So again, type 2 is monoclonal IgM against the polyclonal IgG. Type 3, it's a polyclonal IgM against a polyclonal IgG and also has rheumatoid factor activity. So type 2 and type 3, we can sometimes call them mixed cryoglobulinemias because, again, we have an IgM and an IgG involved. Okay, by far, and I don't have to tell you guys this, you guys are the experts, Hep C obviously is the most common cause of cryo, but nowadays, you know, because Hep C gets treated so effectively and because it's very well recognized by the clinicians, We tend to see a little bit more like type 2 cryo related to Sjogren's. That's a very common cause of cryo as well. And obviously lymphomas like CLL. And for type 1 cryo, usually patients have Waldenstrom's or multiple myeloma or B-cell lymphomas. There are less common causes, and I just want to bring your attention to like bacterial infections because, we talked about, the endocarditis being able to cause like a proliferative GN or a crescentic GN, even trigger some ANCAs. Well, those same patients can also develop cryo. So just let's keep in mind that cryo can also be due to bacterial infections. The morphology that I mentioned, no need to repeat it, an MPGN with hyaline thrombi. Sometimes you can see subendothelial deposits as well. All right, so it's really difficult to definitively, we can make a diagnosis of cryo, but we cannot always make a definitive diagnosis of the type of cryo. In the first case that I showed, or the only case I showed, when you have clearly M kappa or a G kappa that the patient has known circulating cryoglobulin or positive cryocrit, then it is a type 1 cryo, right? No, that you can't argue with that. But sometimes when you have GM kappa lambda, like in this case, the M and the kappa was brighter than the G and the lambda. So this case is very likely a type 2 cryo. Am I 100% sure it's not a type 3? No, but this pattern of having like a dominant like M kappa with a weaker G lambda is quite characteristic. But of course, you guys have clinical tools that will help you make the ultimate distinction, right? You can do an SPEB, you may see an IgM, if you see an IgM kappa with rheumatoid factor activity, low C4, that's likely a type 2. If you do not see that, then it probably you're dealing with a type 3. Although I'll be honest, in clinical practice, we don't tend to see type 3s that often. And in fact, there's literature that says that type 3, it's a transient stage, and eventually they become type 2 or they disappear. But anyway, don't take my word for it. So substructure, I just want to, and I'll finish with this. You'll read in all the textbooks that cryo, has an MPGN with hyaline thrombi, it stains for blah, 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 everything that we discussed, and it shows substructure by ultrastructural examination. Let me tell you, this is the exception rather than the rule. I wish this was true, but I can tell you that a vast, vast majority in real life practice will not have a substructure. So if you're wanting to hang your hat on substructure, you're going to miss most cases of cryo. But sometimes you do get lucky and you see it. I do want to emphasize one thing on the IF that I forgot. Because our theme is C3 only diseases, we included cryo here. But frequently, cryo is not masked. So cryo is not one of these diseases that you need to do the antigen retrieval and do paraffin immunofluorescence. In a significant numbers of cases, you don't have to do that. Your routine can show this pattern, but there are some cases that are C3 only, and when you do the paraffin IF, it shows this. I didn't want to send you with the wrong message that cryo is always masked, because it's not the case. All right, and I think this is my last slide. So if you recall, type 1 cryo, it's a monoclonal immunoglobulin. Type 2 cryo, it's a monoclonal IgM against a polyclonal IgG. Therefore, type 1 and type 2 cryos are considered MGRS lesions. I'm going to repeat that. Both type 1 and type 2 are considered MGRS lesions. Type 3, it's not, because it's polyclonal against polyclonal. But type 1 and type 2 are MGRS and should be treated with clone-based therapies. All right, that's all I have. Shri, do you have something to say? You want to wrap up?
This was excellent. Alejandro and Chris, both of you did an excellent job. I don't have any further questions. This was a very engaging conversation. Our attendees also had a ton of questions, and it was very good. So I really appreciate everyone. And we will take half an hour break, and our next session will start at 11:30, and it is acid-base fluids and electrolytes, and entertaining approach to important concepts in kidney physiology, basically. So at 11:30, we will group again. Anything you want to say, Matt?
Oh, no, that's really, really fantastic and a lot to learn. And let's shift over to acid-base fluid electrolytes with Joel Toff and Leticia Roland, and really looking forward to this. So everyone get their calculators out and let's calculate some numbers here. Have a good lunch, everybody.
Yeah, okay, bye-bye.